Hi everyone, I'm John from HTN and welcome to this webinar today, focusing on a concept of the Everywhere Hospital. So this webinar will provide a thought-provoking discussion and visionary idea on what if hospitals were not places and what happens if we started again within healthcare. So the Everywhere Hospital concept is a radically new model for healthcare that goes beyond the digitization of existing assets, and it's inspired by disruption and challenges like Monzo, Netflix, and Amazon, and brings the concept of a traditional, it challenges the concept of a traditional structure and repositions healthcare and repositions hospitals as a decentralized, tech-enabled, patient-centric service embedded in the community, powered by data and designed to prevent illness before it begins. So it's a really fascinating concept that we're here today to share with you and discuss and hear your views. So I'm really keen to hear what you think. And if you have any questions for our panel today, type them into the chat and just let us know your views as well. So I'm pleased to welcome our panel joining us. We welcome Dr. Gurnak Dosanjh, the Deputy CCIO and Clinical Lead for Frailty at Leicester, Leicestershire and Rutland ICB, and Mike Hardman, the Principal Engineer and EPR Technology Lead at Aire. So thank you to Mike and Gurnak for joining us today. So just before we kick off, a couple of housekeeping things to cover. This session is being recorded and will be shared at a later date. The HTN team will be doing a write-up, so you can read about the key discussion points of the session at a later date as well, and share those with your colleagues if you want to. And then, like I said, if you have any questions at all, we encourage you to type them into the chat and do that through the session. We'll keep an eye on those, and we have a planned Q&A towards the end as well. So let's get started. I think a good place to start is if I could ask the panel to introduce yourself, and if we could do some wider introductions in terms of your role, remit, and your responsibilities in organisations. So Gurnak, welcome to the webinar. Can I start with you, please, for a wider introduction?
Yeah, thank you, and it's lovely to be here today. So yeah, as quite rightly mentioned, I'm a clinician by background, so I'm a GP, which sounds very odd. Why is a GP talking about hospitals? But I've also been very lucky to be involved as a clinical lead for our local ICB, which is Leicester, Leicestershire and Rutland, across many different work streams, including the emergency and emergency care pathways, virtual wards, frailty, and cancer care. So I'm really seeing a lot of kind of what happens in the hospital on a day-to-day basis, and kind of how some of that is operationalized and how it's processed. And with my hat on as Deputy CCIO, I'm also seeing a lot of the digital transformation that's happening within the healthcare system as we speak. So yeah, that's a bit of an introduction to myself. Thank you.
Thank you. Mike, can I come to you for a wider introduction?
Of course. Hi, John, and hi, everybody. Thanks for inviting me here on this wonderful webinar. So I'm Michael Hardman. I'm the Development Practice Lead, Principal Developer, and as you said, EPR Technology Lead at Aire. We're a health tech consultancy. If you've not encountered us, we work across a wide array of care settings, local, regional, and national level projects. I get to work with an extremely broad range of health technology and, again, an extremely broad range of care settings. I'm really excited to be able to share this concept today. You know, it's born out of a lot of conversations with people across all of those areas where I've worked, both internally to our company and externally in both the NHS and other private care settings.
Great, thank you, Mike. And I think that's probably a good question to start us off, really. What is the concept? Can you take us through the concept of the Everywhere Hospital?
Yeah, so a little bit about how we started. It was a discussion around transformation and evergreen EPRs between myself and one of our founders, Dr. Michael Hardman, as well as our Director of Health and Innovation, Dr. Harry Thurkettle. And it just grew out of that into what are we thinking about healthcare from a software perspective purely? Like, we've seen industries transformed. Like you mentioned, challenger banks reshaped finance, Amazon reshaped logistics and infrastructure, Netflix has changed media, and we wanted to explore what such a revolutionary change might look like in a healthcare setting. What happens if we didn't have hospitals today, but we had all of the technology we have? How might we approach that as a problem space given today's technology, and use that as a sort of launching point for whether there's and explore any areas where we might not be doing existing transformations. So we wanted to use it not as we're not trying to say here's how we think healthcare should actually be. We're just wondering if that way of thinking about it opens up any areas that we might have missed, and maybe that we're not talking about at the moment. And equally so, along the way, maybe there are aspects of our health service that we could reinvent from the ground up without being too disruptive as well. So that's the core of it, really.
Fantastic, thank you, Mike. And we'll add the document into the chat so people in the audience can read it and see what's involved in it. But could you just give us a brief overview, Mike, of what the principles are of the concept?
Sure, yeah. So it's not just a hospital with better IT. It's a fundamentally different model. It's a care system designed from the ground up to be cloud native, AI enhanced, as is currently in vogue, operationally lean, and primarily, I think the term relentlessly patient first is a really good way of putting it. Some notes like virtual ward has just been mentioned in the chat, but think like instant triage, smart automation, remote first by default, which I think the smart words touches on, real-time outcomes, tracking, all running on the kind of infrastructure and culture that you'd expect from a tech startup rather than from a health trust. I think we can already see some aspects of this concept being brought forward in our existing health system. A notable example for me would be like the NHS app is starting to become more of a useful entry point for a patient's journey through the health system. And other parts, such as the inversion of data ownership, are likely to be much more controversial, at least on the surface. So that's I want us to sort of talk about how that it's a change to a core philosophy and infrastructure and kind of operating model, and how that would look today. Not to ignore the real challenges that we face in making this a reality, and we explore that in the report a little as well. We accept that none of this is delivered as being potentially easy, but equally think that if we can get some of this right, we could build something that doesn't just patch broken systems, but reinvents them. Yeah, and equally, sorry, I'll just add one little note, one more line. We're not claiming to have all of the answers here in this either. This is intended to be a starting point for this conversation, and to try and draw out some of the questions and those difficulties that we're not aware of. We understand that everybody knows all of the answers, and equally, we don't even know all of the questions yet. So we hope that something like this starts that discussion.
That's a good point. What are those questions that we need to tackle? And that's maybe one for the audience too. If you have any questions, type them into the chat. Gurnak, what is your perspective on the vision, and perhaps what are some of those challenges that you can envisage in that journey towards it?
Yeah, thank you. I think I'd like to start off by just picking up on a couple of points that Michael kind of raised there. And I think that the first and foremost is that, yes, something like this isn't intended to be the answer of everything, but what it should be doing is it should be starting to trigger people to start thinking in a different way. I think when we look back at a lot of, and I saw someone very quickly in the comments flashed up something about virtual wards. When we look back at a lot of our digitalization processes, what we often end up doing is looking at what we do in a physical analog way, and we bring in a bit of digital technology to digitalize it. In my opinion, that isn't true transformation. And what we end up doing is we end up layering on layer on layer. We're not being really, really transformative. We're not being kind of, we're not doing an Amazon type approach to actually completely rethinking how do you shop. And in the same way, I think that's what we need to start getting into that headspace of actually how do we start to rethink how we can offer healthcare to our patient populations? Because let's face it, what we're doing right now isn't enough. We don't have enough workforce. We don't have enough capacity. We don't have enough estate to match the demand on our healthcare services. So we have to start asking ourselves some of these tricky questions. Actually, does a person need to be in a hospital at all? For the care that they're needing, or have those services been built up because actually it's easier to have all of the clinicians, all of the outpatient clinics all in one space, and we get everyone to come to us instead of us going out to them. So the question for my mind automatically suddenly becomes, okay, hang on a minute, are we designing healthcare services on the needs of the service and the system, or are we designing it around the needs of the patient? Now, to be completely fair, I'm probably going to be still a bit contentious around here, because I do think that there are, or maybe provocative, I think there are still lots of challenges in this type of model. There's going to be lots of challenges in how we get there. But I think there's a purpose behind that, because I think if we start to ask those tricky questions of one another, we can start to explore it. And like Michael said, we don't all actually understand fully what all the questions are yet, so we can't come up with the answers. But part of this discussion should be about, how do we realize this? How do we get to that point? And how do we move in that right direction so that actually we can start focusing on completely transformative models of care, a complete new outpatient service, a complete new inpatient service. I mean, we spoke about virtual wards, or someone mentioned virtual wards already. But actually, we need to also be asking ourselves a question: does a patient need a virtual ward? Is there something else that is more optimally available for that individual? Are we just replacing the physical for the digital, like I alluded to earlier on? Or actually, should the question be, in the first instance, does this patient need to be in hospital at all? And these are the kind of challenges that we need to start to discuss and focus on. And hopefully we'll be breaking into some of those earlier as we progress through the conversation.
Absolutely.
You touched on a great point there, and the way I like to talk about this is, it's not a hospital with technology, and it's not a hospital being transformed by technology. It's what happens to healthcare if we use technology from the get-go. It's healthcare and technology, not healthcare with technology. It's a subtle difference in framing, but it's more a symbiotic relationship between the two, rather than a sort of, let's just digitize existing items that we have. Like, really thinking about what is possible with technology and whether our existing structures do indeed make best use of them.
Can I just add on to that point, Michael? Because I think you've made a really valid point here. Unfortunately, when we're talking about transformation, or we're talking about new processes, digital is often the long lost neighbor, because we're so focused on doing things in a very particular way. We're so focused on, okay, how can we make things more efficient? How can we operationally make them better? That often the digital aspect of things, which we're recognizing now, there is so much value in digital. It's thought of almost at the 90th minute, to use a football analogy. What we need to be doing is, we need to be considering how we can bring those digital conversations in, much the way you've said it, in that symbiotic relationship from the offset. Because it's not just the digital transformation that we've got to focus on, it's also how we use that digital transformation. How do we use the data from that digital transformation to continue to inform what we're doing, which right now, unfortunately, isn't great. So even when we're looking at improving our existing models of care, sometimes we just don't have the data because it doesn't exist. Sometimes we have the data, but it sits in a completely separate space. And so if all of those things had been discussed at the offset of a new system or a new service, it could have really been mitigated. And that also has a real tangible effect on continuous quality improvement, which again is another possibly separate discussion, but we need to build that into our everywhere hospital.
Absolutely. We've had a really interesting question come into the chat. Keen to know what kind of data needs this approach generates, and how can we meet them? Good question.
Gurnak, I'll let Gurnak go, please, first.
No, yeah, I mean, I can jump into that. I think before actually talking about what data we need to generate, I think we've got to address the culture around data and data collection. There is so much data that is unobserved, and what I mean by that is, it's there, it exists. We've got no way of actually tangibly capturing it at all, and so it remains unknown. We've then got data which we do collect, but we might collect it in a way that isn't particularly useful. And then we've got data that we collect that is quite useful. And actually, I think what we need to do, and again, we need to start thinking about how we can tap into this concept of, almost like a digital first approach when it comes to data, to try and understand how can we get the most out of the metrics that we might need. And it can be very patient focused, but it can also be workforce focused. I was having a conversation the other day, how amazing would it be, and I'm not suggesting this is one of the answers here, but how amazing would it be if we knew exactly where the nearest acute doctor, so a doctor that would look after a patient who has just had a crash call, how useful would it be if we could send out a signal to the 5 closest doctors, rather than to a doctor who's on the other side of the hospital and has to run across the hospital to go and match that crash call? Now, if you think about it, we've already got those types of technologies out there. We've already got GPS trackers. We pretty much know where we are thanks to our phones. But again, are we having those conversations about reimagining care, or are we just replacing the good old-fashioned bleep with a digital bleep or pager? Sorry, Michael, I'll hand over to you.
No, I want to add on to that a little bit before I talk about the bit that I was going to do. It's not just, again, about tracking of those doctors who might be closest. There's also a whole equipment notion to that as well. Get me the nearest cart. It's not just a case of or specialist piece of equipment that might be needed, rather than needing to sort of escalate through. There's a possibility of just understanding that location-wise data separately to kind of the health data that we might talk about in this context. That is an avenue that we hadn't even really explored. We explored logistics a little around things like supply chain and just-in-time delivery of items, but not in terms of like asset and actual individual location-based awareness that could come through this. But what I wanted to talk about in that specifically around the types of data that needs in here, I think part of the thing that we struggle with, again, nationally and at a trust level, is that although we do have a lot of good data standards, they're still implemented in a very diverse way across our estate. You might have 3 different trusts all with the same EHR implementation, but actually they all store their data within there in vastly different ways using different data models. And we have got some initiatives happening across at the national level to try and build, a national shared care record, which is part of the puzzle in this space, I think, that we really need to get on top of if we're going to provide this kind of transformation. That kind of singular store of care data, whatever that may look like, is an important piece in this puzzle. But I think counter to that, part of being patient-centric in this, one of the examples that I've spoken about is a notable example of an interesting type of care record. In Vietnam, all of the soldiers wore a thing around their neck. It wasn't just a dog tag. They actually wore their care record around them, and they carried that with them. So in a field situation, if a surgeon needed to understand something about their history or treatment, it was right there with them, right in front of them, no matter who it was and where they were. So I think a concept like that is not particularly new, but in what ways could we use technology to sort of do a better job of that? I think that the core concept of having the record moving with the patient rather than being in some kind of silo somewhere else is a very interesting avenue to explore.
That is very interesting. Thanks for that, Mike. We've had an interesting comment come in the chat about workforce. And Gemma's put, workforce is our real opportunity for innovation, especially if we're moving outside the community. And clinical leadership can be diverse and come from nursing, allied health professionals. So Gurnak, how can we bring those people into the conversation? Is there a culture barrier, or and what's the clinical workforce perspective?
Yeah, thank you, and that's a really great question. There's a couple of questions in that, though. I think the first one I'm just going to tackle on is the culture, and we spoke about earlier about what barriers there might be, and again, I'm not trying to be provocative here, but culture in healthcare is a big challenge. We are used to doing things in very specific ways. And within that, we have teams that are used to doing things in their specific ways. And within those teams, there are sub-teams that are used to doing things in their very specific way. So when you try and introduce change or transformation, it can be met with lots and lots of barriers. We spoke even about data collection. Even those sorts of things are very, very different. I mean, as a GP, I can quite confidently say that I've got GP colleagues that will, SNOMED code absolutely everything. And I've got others that are still free texting in lots of bits and pieces. So we have to really start, and I kind of alluded to this earlier, I think we have to really start at the very least discussing digital transformation very, very openly and very confidently, and actually starting to explain that, this is a way that we can optimize things, but also it's the way that we can reimagine things. And that's the key thing. At the moment, I think we're still stuck. Unfortunately, this again might be a bit provocative and a bit controversial, but I still think we're stuck at the optimizing phase. So we're miles away of thinking about, well, how on earth do I get people to wear a GPS tracker or whatever it might be, going back to that analogy, because I'm still struggling with people logging onto 2 different systems to check the 3 different things that they need to check. And so the conversations have to start moving a bit more rapidly, because otherwise, we're going to be missing out. We're going to be stifled, and that's because we're not willing to change. And I think that's what we have to do now. One of the biggest barriers, and someone mentioned around clinical leadership, I think it was within that question, one of the biggest barriers is that at the same time as we are firefighting, we're being asked to change. And that's a real big issue, because, I've got to see 30 patients in a day, right? That's going to take up a big chunk of my day, and then I've got to do all the admin bits and pieces. But then I'm also going to be asked to try and transform the way the practice runs. I've also got to get home and tend to family and all the rest of it. So I think there's something really about making sure that our clinical leaders have got the headspace to start thinking strategic. But I also think the workforce is incredibly important in this. This shouldn't and doesn't need to be top led. I think what we need to be doing is being better at exploring what the problems are at the coalface. What are our workforce experiencing on a day-to-day basis? What are the innovative ideas that they could see could help? And then once you've got that innovative idea or that innovative problem, you then need to backtrack and start to understand what is the exact problem. So often what we see is someone may say, okay, this is a problem, here's the solution, but actually that isn't the solution, it just compounds the problem. Again, famous quote, if I had an hour to fix a problem, I'd spend 59 minutes of it understanding what the problem is and 1 minute solving it. We've got to start getting into that headspace, which is really difficult to do when you are firefighting. And so, but that is the kind of direction that we need to move in. Mindful, I might not have answered the question fully, but I hope that's a bit of a start for 10, and I'll let Michael jump in, because I can see he was nodding his head.
Yeah, nodding away, because I think I agree fundamentally with all the points. And I just want to expand on that as well, that part of this is about being serious about that. It can't be innovation sort of for its own sake. It has to be led by the real need for it. But equally, it must also be inclusive and ethical and human. We're talking about this as a technology solution, but the fundamentals of all of this is all of these problems are human problems, right? It's all about how we interact, both as clinicians and support staff and patients, and all of those aspects of it are human. And the sort of core element of healthcare is treating the human condition, right? So all of this is a human scale problem, and I want us to start looking at how technology can help with those human-led problems, rather than just augment the old. I know we've covered that same point many times, but we've developed these processes and practices without technology, and all we're doing is attempting to digitize those, and I'd like to see us think about and be conscious of technology today when we're thinking about solutions.
Can I just jump in, because a thought came into my mind as I was kind of rereading that question again, and there was something around, not all clinical leadership needs to be medical. It doesn't need to be coming from that kind of same background. I think you're so right here. And again, I think there's something around kind of compassionate and engaged leadership models and styles when we start to think about how we transform healthcare. There's a great story I heard once around a GP practice where so the problem was patients were not happy with the way that the waiting room was kind of based, because when they'd enter to talk to the receptionist, they'd have to share everything, and all the people waiting in that waiting area could hear everything. And so, all the partners and practice manager and everyone was sitting, the nurses were sitting in the room, and they were discussing it, saying blah, 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 how can we improve this? And they couldn't come up with a solution. There wasn't enough room to move, to change things around. They couldn't build a separate area where people could go and talk about things. And one of the DPs happened to be talking to one of the cleaners. And the cleaner said, oh, that's really easy. If we move these chairs to here and we move this thing to there, actually you create a barrier here, which might just work. And now for that cleaner was doing this on a daily basis because she was constantly cleaning the waiting room. And so she could see it from a completely different perspective. But it comes back to that same point that I spoke about earlier. is spend the time understanding what the problem is, bring the right people into the room. So when I say, we need to understand what the coalface are experiencing, this isn't lip service. I'm not trying to say it to tick the box and miss the point. I'm saying it genuinely. Bring the right people into the room, because that will help those leaders understand how to best manage that problem and best come up with that solution.
Absolutely, very good point, Gurnak. In Mike, question for you. So in the Everywhere Hospital concept, it plays a notion to Monzo and disruptors.
Mhm.
And healthcare is often compared to Netflix, and people want healthcare to be more like Netflix, and that's used quite a lot. But what could we potentially learn from those disruptors? Is there any takeaways?
For me, they took what I would describe in this context, a patient-first approach. Like if we look at Monzo specifically, they took banking as a service and made it as smooth a possible journey for their users, and made it as informative and open and clear, and took them along and made you feel like you're a part of the banking process. They opened up the whole of it to you, and they made it really, really easy. It's easy to sign up, it's easy to engage with your money, it's easy to interact with that in that space. And the other challenger banks do that too. The older, more institutionalized banks are still playing catch up in that space. Again, because of their legacy. They're huge banking systems that weren't built for a modern app-led world, where instant, immediate access to that kind of data and insight wasn't built in from the ground up in their core systems. And I think that's the kind of takeaway and that's very much what led to this whole thing, right? All of our systems in healthcare aren't built for that patient-first journey. Patients are not driving this; they're consumers of it. They're not an active participant in the healthcare service. They just are a consumer of the services that are kicked out. And I think that's the kind of fundamental mindset shift that we go through in this modern world, is that as a patient, potentially myself, I would like to feel like I'm an active participant in that journey, and not just somebody who is consuming these services and being given those things. I think that's really at the core of this whole piece.
From an infrastructure perspective, what do you think needs to happen in the short term? So we've spoken a bit about data, but what about the underlying infrastructure? How can that help us take, say, a step forward in the short term?
Well, we're already seeing a transition in hospital settings to use more cloud-based services, allow that kind of elastic scalability, allow the kind of responsive infrastructure that is needed to support something like this. A traditional, rack of servers hiding in a room in a hospital is not really going to be appropriate to support this kind of shift. It needs to move into a more distributed and decentralized form in order to handle the kind of immediate access and workloads that we're talking about. And I think there's already a recognition in things like patient portals that the services that I've worked on, we still have core EHRs hosted internally in the hospital, but patient-facing portals that might suffer unexpected and unpredictable workloads end up being farmed out to the cloud. In services like Microsoft Azure and AWS and others. And I think it's that kind of a shift that we're already seeing. And I'd like to see us again take that a step further into, now let's start putting more core hospital services up there as well. And is there a compelling reason not to do that? So far, I'm not really finding one. That's not to say it doesn't exist, but the only reason that we don't do that is, from my experience, a sort of distrust and equally a kind of discomfort in the notion of letting go of that control of that infrastructure, rather than there being a compelling service-related reason for doing it or not doing it.
And Gurnak, what's your perspective on this? Do you think healthcare is quietly being commoditized, and are Amazon and Monzo the consumerist models? What's your view on that?
Yeah, I think when I first picked up the report, I think that was probably one of the first things that went through my head, in all honesty. And I suspect there'll be other people out there that are probably thinking the same. How do you replicate what a company like Amazon and Monzo, which, yes, they are very customer centric, but they're customer centric for the purpose that more customers equals more money, which equals more points and prizes, so to speak. Whereas as healthcare, certainly in the UK, is very, very different. It's not a consumerist model. Unfortunately, we are confined by budgetary constraints and what we are given to kind of manage the healthcare needs of a nation. So it is a really, really different model. But there's still a lot that we can start to think about and we can start to borrow from there, especially around efficiencies, because we say that yes, we have budgetary challenges, but it's still something like £204 billion within healthcare. So it's not a small chunk of change, and this is taxpayers' money that is being kind of reused to support that healthcare. So we have to start understanding, and we have to ask that question: are we getting the best value for every single pound that is spent? And if we're not, we need to ask why not. And often, one of the things I've started doing, certainly in lots of meetings, is if someone is saying, actually, I don't think we should change this model, I'll say, okay, well, is the new way of doing it, is it going to be more efficient? Is it going to be more clinically safe? Is it going to be better for the patient? So, do we stick with the status quo because that's what we're used to doing, and that's the thing we've always done, and our culture suggests that we shouldn't change it? Or should we start moving to a culture where actually we're interested in transforming, be it using digital tools, be it using other technologies, be it kind of physical, or just doing things in a different way. And some of that comes from these types of models. It is seamless. It's absolutely seamless for me to jump onto one of those websites and order whatever it is that I need, or order a book. It's nowhere near as seamless for me to know what my blood test results were, when my next hospital appointment is, or even how long I'm going to have to wait, to see my GP whilst I'm in the waiting room, or if I'm waiting in an outpatient clinic, what the waiting time is. Again, these are all things that, using digital models and digital transformation, we could start to put some answers out there. So I think, yes, okay. Is it a quiet commodification of healthcare? I don't think it is. I think we need to start embracing more from other areas, other industries, on how they are doing things and how they're working. Now, I don't know, I might be jumping ahead of myself, but I'd just like to touch on this point. I think when we looked at the banking service, there was a big fear that all of the banks will close down and they'll no longer be there. And there will definitely be people that will need to, go in to a physical space. And to a certain extent, we have seen some of that happen. I don't think we're ever going to see that in healthcare. There's always going to be a need for people to come to hospital. There is always going to be a need for people to have operations. There is always going to be a need for people to receive urgent and emergency care. That's always going to be with us. What we are saying is, at this point in time, we haven't got enough of those things to match the demand. So we need to start trying to get to a place where we can figure out who are those right people, so they're in the right place at the right time. And how can we better serve those that might not necessarily need that hospital setting, but could be looked after in a completely different way.
There's a point in chat that I think is very relevant to exactly that. Namely, there's a lot of data that we're not using at the moment, such as wearables, and those kind of preventative lifestyle interventions that are happening based on private genetic testing, nutritional insights from that privately sourced testing as well. It's a really great point, and again, it's something that we have covered briefly in the report. But it's those kind of insights that can allow us to respond to need, hopefully before it becomes critical. That's, I think, the whole point around this model is if we can engage people in their own healthcare earlier in the process, we should be able to reduce the load on those still required pieces of infrastructure. If we can catch somebody and help them adjust their lifestyle before they develop a heart condition, that's one less person having a heart attack, going through ER, or requiring an ambulance coming out. And surely that's a win for everybody, right? For those unpreventable and unexpected and accidental issues, they're going to see a better health response. Whereas if we can bring people on the journey of their own health in a kind of interactive and engaging way, that makes you a part of that journey rather than, as I say, you know, a passenger on it. We should be able to, ideally, reduce the overall load on those still fixed pieces of infrastructure that we know we're never going to be able to get rid of. People are always going to, you know, fall over and break a leg, or have some other kind of unexpected, unplanned, unanticipated incident that requires an in-person visit. But there are certainly a lot of preventable issues happening to people that still lead them to ER today. And things like wearable tech and those other kind of genetic insights can go a long way to helping prevent that. I think we're starting to see it, right? It's just how do we bring that in to the service in a coherent and interactive and nice and friendly way?
Yeah, can I jump in to kind of follow up on that? Because
Please.
I want to be a bit provocative here if I can. Again, I feel like I'm being the contentious guy. I feel like I'm being the Simon Cowell in the room at the moment. But intentionally, because I'm actually quite surprised that no one's asked this yet. You know, this tech, surgeons, you know, wearables, etc. You know, the first thing that always brings to my mind is, are we leaving the rest behind? You know, are we creating a system that is really, really good for the digitally literate, those that are perhaps more economically mobile, that, you know, they can afford to buy these sorts of devices? And are we at risk of leaving those behind, you know, that can't, either from a digital literacy perspective, they can't join in, they may not have the financial resources to join in. So there's something really real and tangible about that digital exclusion piece and that healthcare inequalities piece. And what I'm not suggesting is that we don't do it because of that, but I'm suggesting we need to consider the impact that whatever we do, we already know that health inequalities exist. We already know that those from, you know, the worst socially economic deprived areas of England have far worse health outcomes. So we don't want to kind of double stack on that by creating things digital. But, you know, are we at a risk here of kind of leaving people behind? And so that, for me, I think there's something around making sure we are creating systems for the most excluded. And I think we need to start asking, and actually not just asking those questions, I think we need to start having those discussions, like, quite openly, so that no one does get left behind. And Michael, I'd just be interested in kind of hearing what your thoughts are around that, because I'm sure there'll be others that are probably thinking the same.
No, absolutely. I think it's clear for the most part that we are becoming increasingly more digital native generationally. But you're right, there still remains, even in, I think, the latest cohorts, that people that will not have the access to the kind of modern technology that lets them, you know, post TikToks, which is what we're talking about being the need to engage with a system like this, right? So, and I think that does remain an unanswered question. Is there some way that we can provide that level of engagement and interaction with the health service that doesn't exclude those folks? And I think at the same time, those people are excluded now anyway, right? If they've not got access to a smartphone, they're not probably going to have, easy access to their local hospital. They've probably not got ready transport to it. They probably can't get to their GP. I think that problem exists right now anyway. And what we're potentially doing by changing to a model like this is allowing something such as a relatively now cheap and commodity device that could even be provided to people in these kind of more impoverished settings, that will have a net gain on our overall health costs. Because if we could provide you know, some of the more impoverished areas with wearable technology, doesn't mean that we're giving them access to, you know, dangerous services. We could ultimately end up saving our overall health bill in that area. You know, these relatively now cheap devices are increasingly becoming more commoditized and easy to produce. And I think that instead of spending potentially, you know, billions or whatever on providing additional infrastructure in those areas, we could be providing them with some relatively cheap technological devices that allow them to take a more active role in their health on the day-to-day. I think there is a potential for it to address both of those concerns through technology, and potentially leave us better off than we are even today.
You know what, Michael, I think you've hit on a really good point there, actually, one that I hadn't perhaps considered coming into this discussion, but actually I think is really valuable. And I know you mentioned the word cheap there, but actually cheap doesn't always mean optimal.
Oh, you're right. Yeah.
And actually, you know, if we took this one step backwards, and if we looked at some of the, you know, social indicators, that contribute towards poor health, etc. So things like education, things like access to a good support network, things like even meeting your relatives. If we only have to think back 5 years ago and what social isolation was doing to people, and if we start to think wider and more broader, my daddy's in his 60s, but he can pick up his iPad and he can pretty much enter most parts of the different world. He can speak to relatives in India. He can do some shopping. He can do some online banking. He can catch up on the news, etc., etc. So there is a real art of the possible that healthcare could actually start to engage with by saying, you know what, actually here is a device. We don't need to lock it down. These are adults, to be fair, right? These are adult individuals. But here's a device that we know can support your healthcare needs. It might help you access, an appointment quicker. It might look after you on a virtual ward. It might do X, Y, Z. But actually, again, if we start to understand what the problem is, we can actually start to think big around this. We can start to think even broader than the hospital. We can start to think about our GP services. We can start to think about our community services. We can start to think about mental health services.
Yep.
And I think it's about having that kind of brave response to say, you know what, yes, okay, it doesn't fit neatly into the healthcare box. We are saying this from a healthcare perspective, but there are other tangible benefits that we could get from this alongside the additional training, right? So we can't just give a person an iPad. We've got to teach them how to stay safe online. One of the first things I did with my father, again, sorry for the personal example, but was, I said to him, look, if you get a link or someone sends you an iMessage saying, click this because you're due a COVID jab, actually, you might need to ignore it. It might be fake. Someone might be trying to fish for your data, or they might be trying to get your credit card. So you've got to be mindful of these sorts of things. So I think there's definitely something around, again, how we reimagine the offering. And actually, it could go even broader than just the everywhere hospital.
Yeah, and I think that maybe the name, even whilst we like it, is potentially a bit of a misnomer. It's not just about the hospital. That was the starting point, but it's about the complete healthcare journey, right? And you're touching on the right things there, the mental health aspects, emotional and psychological health, as all as part of it. This kind of technology can bring those kind of services and support for those issues closer to people, and also hopefully through the kind of responsive monitoring, like we say, the AI triage can help to raise indicators around risks in those areas and be more preventative. Stop being reactive to a problem and treating the symptoms. Let's start actually getting to the root cause of these items and catching them before they become huge problems, which are then end up having outsized costs, further damage to people, their families. These things snowball when they're left to fester. And technology such as this can be allowing us to get ahead of that and start to be proactive in catching and then treating these conditions before they become chronic or otherwise more damaging.
Mike, what do you think needs to happen in the short term, in the next actually, what is the short term? Is that the next year or two to really make progress here?
Well, we're doing it right now. This is exactly the kind of thing that we need to start doing. We need to start being open about the problems that we have, not just that we have a problem with technology. What kind of problems do we really face in healthcare? Like I talked about, those human-centric items. Let's start to discuss those and rehash some of those areas that we think are actually settled, because perhaps they're not. Let's start to assess them with this mindset of, in what way could we apply the technology we have today to that core problem, rather than just trying to technologize our existing solutions. And that's the fundamental to producing any good system or solution today. We need to review the problem with the perspective of today, rather than trying to just upgrade what we have. I think that really is the core of it, and this is the start of that, right? At least from my perspective, these conversations are exactly the start of it, and that's what we need to be doing in the near term. Discovery, right? Let's get the discovery of those problems, then we can start to really assess whether we think there's an obvious area where we can start to apply thinking like this.
Yeah, can I double down on
Please,
that?
please.
I think Michael, you've kind of completely hit the nail on the head here. I'm hopeful that what this conversation, the reason why I kind of wanted to get involved in this conversation was because I'm really hopeful that it will start to spark some creative thinking amongst those people that are listening in today. And I'm not trying to say that in a kind of patronizing way at all, because we're always creatively thinking, but genuinely to kind of really go away and actually understand what that problem is. I did some process mapping, which is like a really simple way of like kind of looking at what a patient's journey is through a system. And what was really interesting was that different parts of that system, so different components, had no idea what happened after their handover point. And as a system, we had no idea what was happening across the whole system. So there's something really simple about actually just following the user, follow that person through whatever pathway it is. And this could be about how a patient books a blood test, for example, or it could be something as complex as how does a patient go, get admitted for a hip replacement. So there's so many different variabilities there. But I think one of the really nice things is actually spending time with all the different people that are involved in that process and really truly sitting down and understanding what it is, because that's when you start to see, okay, this part here took 24 hours. Why did it take us 24 hours to get the result of a blood test? What could we do to speed that up? Oh, okay, because it was sitting in a different system and there was no notification. The person who checks it wasn't in until the next day. That's why it took 24 hours. And that's happening time and time again across, every single patient waiting on a waiting list. How much added time is that added onto that patient's journey? And now if you then start to think, okay, now the problem is that one spot, how can we digitally improve that? Rather than finding a solution for the overall problem, which may or may not exist. So I think there's definitely something about that. And I'm really kind of, again, very similar to Michael. I think that the next step is that we just have to start having those honest conversations about what we know, what we don't know. And if we don't know it, let's try and figure out what we don't know and explore that. And there's also something really nice about learning from others. I would guess that the similar sort of problems that we're having locally are going to be very similar to the next ICB or to the next acute trust or to the next general practice. I don't think there's any shame in saying, what have you done that's worked really well? Can we take it or try and adapt it? And what did you try that didn't work well? Can you tell us why it didn't work well so we might avoid that same mistake? And again, we don't have that conversation enough in healthcare. I think we could do more of that.
Can I add a little item around around one of the points you made there, which I really appreciate, and it speaks to the kind of questions that I think we should be asking. You raised the point around, a blood test can sit around. You've got a lab that's got a backlog. It's a big lab. The answer that we think usually in most of our hospital settings is we've got a backlog of tests. Can we expand the lab? Let's make it even bigger. Right, let's bring some more machinery in. Let's have even more. And what we end up doing when we do that is we actually reduce our agility. We now have an even bigger lab with even bigger systems, and we're now even more entrenched. And now replacing that is an even bigger ordeal, and so we end up with systems that are aging out in those contexts. What if we were to turn that on its head and make it a lot smaller? What if we have more smaller local labs? What if we have a phlebotomist and a lab sitting together? Right, so you have your blood taken and it's tested immediately. Why wait around in a queue? That's the kind of inversion of thinking that I think we need to be looking at. And not saying it's definitely the answer, but it is at least something that I think is potentially worth exploring, especially given, again, the further commoditization of things like lab testing equipment. There are small individual multi-blood testing solutions available to us that doesn't involve a massive, huge laboratory and a huge number of lab technicians managing and running this huge machine. It could potentially be a small desktop item that a single phlebotomist can actually run, and they move from place to place and do blood tests of a particular set of types. That's the kind of thinking that I think the Everywhere Hospital is trying to promote. Is that an answer to our ever increasing and ever expanding hospital infrastructure that, again, is, bigger is not always better?
Really like the term "what if we could do something," and that's great for idea generation, isn't it? And like, no ideas is a bad idea. So Gurnak, question for you: what if we had unlimited funding, time, headspace? What if we could do what we wanted to do? What would that be? What would that look like for you?
For me personally, I think That's a really interesting question. So unlimited funding and no cultural or other challenges. I think for me, I would want to try and make healthcare as seamless as possible for the patient. That's the number one thing. I think it would. There are a number of patients who have to go into a hospital to have some form of assessment done, which could very easily be done remotely or virtually through the right system, through the right technology. There are a number of patients who, end up in hospital and stay in a hospital bed for many, many days when they don't need to be. They could be looked after at home. There are many times that there are missed opportunities to detect an illness that we don't pick up because either the patient doesn't recognize it, or when they do recognize it, they don't have timely access to healthcare. So I think we need to be reaching back into those individuals, using those hard facts, the fact that the person has had a temperature or the fact that they've got a particular symptom of note. I think that also resonates across cancer. So if we think about patients with cancer, there are lots of opportunities to pick up on cancer, but either because the patient hasn't recognized it's a significant symptom, or they haven't had the right access, or there's a cultural barrier to address or investigate it. It doesn't get investigated. So there's, again, we're as a nation, we're not great at picking up cancer at the earliest phases. We could do more. So that's the kind of the vision that I would see. In terms of how we would get there, I think we need to start thinking about how all of our technology lives across the system and talks to one another in a really seamless manner. Right now, I've got no idea what's happened to a patient in the hospital. No idea at all. But actually, that information as a GP would on some occasions be really, really useful. And in a similar way, the information that secondary care have is very limited to what's happening in the community, let alone what's happening to the patient when they're in their own home. So we really need to start crossing some of those barriers. I definitely think there is an interesting concept. We've not really had much time to talk about this today, but there's a very interesting concept around should the patient hold their own data, so that they are the owners of that data and they give the access to the individuals at the time that they need. So much like those Vietnamese soldiers, they carry it with them at all times, just not in the neck, just in a different kind of cloud format. And most of all, what I'd like to see is that we all embrace the change, because I think that's what this comes down to ultimately is, even if we bring in all the fancy tech today, everything is brilliant and I've got my dream wish and everything is perfect. In the next 5 years, healthcare is going to change again. Our needs are going to change again. So we need to continue to embrace it. We need to continue to move. We need to continue to evolve, because the needs are always going to evolve. And so, one thing will just get replaced with the next thing, and who knows what that might be. But the point is that as a culture, my ultimate wish would be that actually we're very good at doing is being agile and rapidly embracing change. Right now, change takes a very, very long time. Lots of governance, quite rightly so in some instances, but it's slow. It's slow moving. To introduce anything can take many months, and if not, sometimes years. So again, we need to kind of shift that culture as well. So 3 different aspects there from me.
Great point. Great point. Thank you for that, Gurnak. And just before we go to some of the comments and questions in the chat, Mike, have you anything that you'd like to add?
Just one little bit there, and I think what you say resonates strongly with at least the way I feel about all of this. And I'm not coming at this from a clinical perspective, obviously, but I think there's a really important aspect of clinical world that it's called practice. Right, it's called practice because there's a fundamental expectation that at every step of the way you're going to be learning from it and growing and changing what you do in response to that. It's very specifically chosen language, and our existing systems are built in such a way that they get procured in these long cycles. They then get rolled out and released in these again huge cycles, and almost at the point at which they start being rolled out, they're already out of date because the practice has moved. Right, so changing that mindset to the real core of what birthed this whole idea, which is the notion of evergreen technology. We want these kind of systems to be moving along with the moving practice, not being things that are kind of out of date before they've even become widely used. So that's all that I'd like to add to that part of this is, trying to bring technology along in the medical development journey.
Excellent. Thank you, Mike. We've had an interesting comment in the chat from Gemma, who talks about virtual wards and how they're supported by families and the positive experience. But she's put we need to make sure that there's always a choice and a menu of support that's offered, I guess, whether it's digital or physical support in whatever instance. So that's a great comment. And then Anthony's come in and said third parties tend to hoard sets of patient data for each system, creating monopolies, and we need to choose systems based on how they integrate with other systems. What's your view on that, Gurnak?
Yeah, I think I'll go into the virtual wards one, and I'll perhaps let Michael wrap up on the data question. I think you're quite right. I think the some really fantastic outcomes of one of our biggest digital transformations that we've done in terms of kind of patient facing, which is the virtual ward program. We've now got well over 10,000 virtual ward beds across England, and people now have the potential to go home instead of being looked after in a hospital. I think choice is paramount, but equally we may need to come to a position where actually the choice is you're looked after at home rather than looked after in a hospital, because how often are we saying to patients that if you're looked after in a hospital, you've got a 10, these aren't the exact numbers, but just for the sake of argument, you've got a 20% chance of picking up a chest infection, you've got a 30% chance of having a fall, and you've got a 50% chance of losing your muscle strength in your legs. Do we tell people that when we admit them onto the ward? Never. But what we should be doing now is we should be educating our patients that yes, okay, historically the hospital has been seen as this physical place. There is no clinical need for you to be looked after here. So the appropriate thing, the clinically right thing to do would be to look after you in your own home. Now, of course, there might be mitigations to that. The patient may not feel safe at home. They may not have the other support mechanisms in place, but at least that discussion has been more informed, and the patient's aware now of the risks of staying in hospital, which may actually very well outweigh the risks of being out of hospital. So again, it's around having those honest and open questions, not just amongst ourselves, but we also probably need to start having it with our patient populations and our citizens as well, which again is probably another conversation for another day. I'm going to leave the last few minutes for Michael to answer that other question.
Sure, yeah, it was about third parties hoarding their data or otherwise, having a bit of a castle that contains their data. And yeah, I think it's a really important point. Namely, we spoke about the kind of inversion of principles and allowing a patient to be the kind of keeper of their records, which that a part of that would open up. But equally, that's not necessarily, as we say, it's not the only way forward. Part of the sort of philosophy of this is an integration and open data exchange kind of led solution, where if we're expecting to have a variety of different services a bit more distributed, then it's really fundamental that they need to be able to talk to each other and interface with each other. And I think by enabling that at a core level, we can start to allow for things like, say, private third parties to engage with that and offer services into it that open up more choice, whilst opening the borders of that data as well. Like if you want to interact with our care system, here is a care system you can plug into, but a part of that is that you will be interacting with this broader network of systems in an open and integration focused way. So it prevents these kind of lakes and silos of data from even forming. You sort of by design saying, if you want to be part of the care journey, then it's implicit that you're going to want care records from us, and we're going to want and need care records back from you, and ensuring that everybody is playing a fair part in that, both from a public and private care perspective is an important part of this kind of transition. We're not saying that the only model is the NHS. Is there a way without digging in and becoming more privatized? Is there just a better way that we can interact between those two sets of services? You might have a fully private healthcare solution, but equally it doesn't stop you from needing to go in an ambulance to ER sometimes, right? And but right now these barriers between the services kind of limit that kind of data sharing in many respects, and that only comes at the cost of the patient, right, and their potential care. My understanding of it, at least.
Fantastic. Thank you both. I'm conscious of time. We've got about 30 seconds left. So I'll just quickly wrap up. So at the start, we said, what if we could create or think about what a new hospital would look like, or if we were to start again, what would we do? And I think we've discussed, and you've brought lots of different ideas of how we can do that, and that's been a fascinating, thought-provoking discussion, I think. And like we've said throughout the session, keep asking those questions, those difficult questions, and I think we've got through some of those today and progressed the conversation, which is, I guess, one of your aims. So I'd like to say thank you both for taking the time out to share your experiences and contribute to this discussion. Thank you to everyone in the audience. I'm sure you found it useful, and we will be doing a write-up. There'll be a recording that's shared so you can start to digest what we've spoken about, share it with your colleagues, bring them into the conversation as well. And yeah, so I'll close the session here. Thanks again, Gurnak and Mike. Great session, and have a nice day, everybody. So thanks again.
Everyone.
Cheers, everyone.
I'm just hanging around seeing the chat. But thanks, Gurnak.
Thank you, Michael. Take care.
Take care.